Hi, and welcome to our Facebook Live session here with the UCLA Women's Cardiovascular Center. We're going to talk about heart disease in women. I'm Dr. Sheila Sani, an interventional cardiology fellow at UCLA, and I'm joined with...
Hi, everybody. My name is Dr. Marcy Press. I'm an interventional cardiologist as well at UCLA, and I'm very excited to be here with Dr. Sheila Sani and to talk about heart disease in women, highlight some of the important differences that may exist, and answer any questions that you might have. So thank you for joining us.
So no discussion can begin without the true history of heart disease in women and why we're even having the webinar. But to follow along and to stay engaged, we want you to follow the hashtag UCLAMDChat, where you can live tweet your questions or follow us live on Facebook, and also send questions through the comments section. So let's begin with a little background that starts in 1964, when the American Heart Association held the first conference for women in heart disease. And what was it called? Hearts and Husbands. That's right. It was a congregation for women to educate them about their husband's heart health. And that's really where the sessions about heart disease awareness were beginning for women. It was about a man's disease.
Say that's one of my favorite slides. It really highlights that the history of heart disease in women really doesn't actually go back that far, and it was only until recently we really started to recognize as a community how important it was. In fact, even after that first sort of mention of women and heart disease in the slide prior, it wasn't even in 1995, at the cover of Reader's Digest, we talked about heart disease in women, but again, it was in the context of our husbands. There was no mention on the cover in 1995 that women could have a heart attack, and our role was really just to screen for heart attacks in our spouses, but not really in ourselves. And one thing we'll be really emphasizing is self-care and the importance of advocating for yourself, not just for your family, but also for yourself. And this is pretty impressive.
And with all of that from 1964 to 1995, what it actually begins to show you when you look at some of the epidemiological trends of death for cardiovascular disease, women in red, leading really up into the high 90s, were suffering and dying more deaths from heart disease compared with men. But then there was a shift. In the early 2000s, you can see that less women were dying. And that has to do with some awareness campaigns and the continuation of them by such things like the webinar today. So we're going to talk about that.
And it also really, really highlights how important awareness is. I mean, have you ever seen anything so dramatic where you could say, wow, women up until 2000 were dying at a higher rate than men, and then all of a sudden from 2000 on, you see a precipitous drop in the number of women that are dying from heart disease. And that really gives us a lot of credit to the people out there who are advocating for women, and that's one of the things I think that drives both of us and what we do. We can make a difference, and I think so can you. So this is why we do these webinars.
Thank you for tuning in. Yeah. So in 2003, Time magazine realized that heart disease is a woman's biggest worry. And that's when the awareness really started to happen. And to piggyback off of this effort, the AHA and the National Heart, Lung, and Blood Institute actually partnered together to create an awareness campaign called Go Red for Women. They created the national symbol of the red dress to really have a uniform awareness platform to educate women about heart disease and heart health awareness. And now there's actually a National Go Red Day ever since this campaign was launched to bring about awareness on male, female, American level. And it's even gone international. Since then, we've actually seen a dramatic improvement in women being more aware of their risk factors, and we've already shown you that the deaths have actually gone down as well. But there's more to the story.
Yeah, so the issue is that even though we've come very far since the early 2000, we still have a ways to go. And this was an article written in the Atlantic, and it was really highlighting why are we still behind? And I think that's one of the things that we really want to focus on today. And the reason that I think we're so behind is that we have to recognize that women and men are different, and heart disease is different in women and men. And I think that some of the reasons for that may be, for example, the way women present in heart disease may have different symptoms than men, and there are some gender-specific diseases that are also different in women than in men, and we will review that shortly.
And it's important to emphasize here that awareness has to also occur amongst physicians. So after listening to this webinar, if you feel something, you are your own best advocate when you're seeing a doctor. And if you need to go a step further because something doesn't feel right, that's okay. Because just in 2015, physicians themselves don't understand the gender-specific differences of heart disease between men and women.
So again, we need to recognize that heart disease is still the #1 killer of women, and it actually far exceeds that of breast cancer. And we know that the campaign for breast cancer, which is wonderful, has been so successful in raising the awareness for breast cancer in women. But heart disease is still, exceeds by at least more than 100-fold in terms of its risk of causing death in women. So we need to always, and I always remind my patients, remind myself that heart disease is still, outkills women in this country.
And it all has to do with the awareness campaigns and the funding that was given to breast cancer. And that's why we're so grateful to the AHA and the Go Red for Women campaign, because it's helping to increase awareness on what's really killing women. But what we have found is, with all the awareness, what you're looking at is actually the change in coronary artery disease in women in different age groups, women and men. And so we've actually seen a decrease in women and men above the age of 55. But what's happening here with the younger population?
Yeah, so this is a really interesting and actually alarming in some ways trend that we've seen, in that the incidence of heart disease in women has actually shifted to a younger population. And the reasons for that actually are probably many, and we'll go through a lot of these in more detail later. But one of the things that we're seeing is earlier development of atherosclerosis. And atherosclerosis is the gradual narrowing of the artery due to cholesterol buildup in the lining of the artery. One of the reasons that we think that this has become more prevalent in younger women is the higher incidence of diabetes, as well as obesity and smoking. In addition, women are at higher risk of having what we call non-epicardial coronary artery disease, or diseases not just of what I like to say the 405, but also, or I'm sorry for those of you not from LA, the highways, but diseases of the smaller roads or the small vessels in the heart. We'll go through that again later in the talk. But as you can see, there are many other causes of heart disease in women, not just your standard coronary artery disease, such as, like I mentioned, microvascular disease, dissections, vasospasm, for example.
But overall, to summarize this slide, younger women are basically being found to have more heart disease, and it really begs the question about early risk factor identification, which means see your doctor regularly and know your numbers. So where we are right now is we've shown you the data that heart disease takes the lives of more women than all cancers combined. And there are decreasing segments of heart disease in some age groups, but young women remain at risk. And there are important differences between men and women who have heart disease in how they present and even how they should be managed. So let's take you through some gender-specific qualities of this disease process. In terms of risk factors, we're going to touch on the differential impact of risk factors. There's certain risk factors that women face when they go through pregnancy. We're going to talk about heart-healthy lifestyle modifications, as well as differences in responses in preventive medications. Dr. Kalfan Press has already touched on gender-specific disease processes in the actual coronary arteries. And we're also going to give you some fun tips and tricks of how you can protect your heart. So let's begin with some gender-specific risk factors.
So the most powerful risk factors for heart disease are smoking, diabetes, elevated cholesterol, hypertension, obesity, physical inactivity, family history, and age. And this is true for both men and women. The risk factors that potentially may be stronger in women consist of autoimmune diseases. So we now recognize that patients, for example, with history of rheumatic arthritis or any inflammatory autoimmune disease are at higher risk of having more aggressive atherosclerosis. And actually, we are now starting to consider that almost a diabetic equivalent disease. And so it's really important, if you have a history of autoimmune disease, to be screened, to ask your primary care doctor whether or not you should be on any specific medications or having any lifestyle changes that may reduce your risk. Breast cancer treatments. Now, this is very important. So women who've undergone chemotherapy and radiation are at higher risk of having both diseases of the arteries, diseases of the muscle like heart failure, and diseases of the valve like aortic stenosis and mitral valve disease. Things like stress, anxiety, and depression, and we'll show you some of the data, can actually have a more powerful impact in women as opposed to men. Women and men deal with stress differently, and stress seems to be, at least emotional stress, seems to be quite powerful driver for heart disease events in women. Sheila mentioned the pregnancy complications. We know that women who have heart disease in pregnancy are at a higher risk of developing heart disease later in their life. So, for example, the incidence, the association of gestational diabetes, preeclampsia, or hypertension in pregnancy have all been associated with increased prevalence of heart disease later. And I mentioned those.
So when you look at women who present, and this is a landmark paper that really reviewed the presentation of women who present with heart attack, and what you can find is a lot of what we've touched on in the previous slide, that women who presented with heart attacks had higher degree of obesity, higher degree of diabetes, they had some renal dysfunction. The risk factor of smoking is actually a higher risk factor for heart attacks for women compared with men, as well as hypertension, and we touched on depression, which is where that self-care component, really we want to prevent heart disease in a woman's heart. So when we talk about depression, anxiety, and self-care and seeing your doctor, it's really to prevent these. And then you have specific risk factors to a woman, which include the pregnancy-related risk factors, menopause, and the use of hormone replacement therapy or the chemotherapeutic drugs that may have affected you during cancer treatment, such as breast cancer. These are important risk factors to keep in mind. If you so happen to see a physician who doesn't think that you're at risk, but you know that you had gestational diabetes, it's an important time to let your primary care doctor know that you went through that during your 20s or 30s when you were of childbearing age.
So I think, I'd like to sort of say something a little bit more positive. I know we've been saying a lot of things that sound quite alarming, but just to kind of give us a positive note, all these things that we've been saying, many of these things, we really can actually make a difference and reduce our risk. And a lot of the things are actually quite sort of basic in the sense that we can make a change. You can make a change today. You can make a change this week, as long as you're aware that there are lifestyle modifications that you can make that can have a dramatic impact on your risk. This is probably our most important slide, because really, if you just don't smoke, you will reduce your risk of having a heart attack by 71%. I mean, that's incredible. So just don't smoke. If you exercise more than 2.5 times a week, your risk of reducing heart disease is up to 28%. If you eat healthy, 31% reduction. If you reduce your alcohol to less than 1 drink a day, you can reduce your risk by 33%. Keeping a normal BMI is extremely important. And so really, if you add up all the activities that you can do, you can actually lower your own risk of up to 92% of having a heart attack or stroke. This is actually really, I think, hopeful, and I think we want to make sure that we give you a hopeful message that just because you're a woman doesn't mean that you're going to die of a heart attack. There's a lot we can do in our lifetime to reduce that risk by almost up to 90%.
And even if, when it comes to the gym and having a more increasing physical activity in your own lifestyle, simple things like taking the stairs, parking a little bit further when it comes to the grocery store, and just getting a lot more movement in your day will actually dramatically improve your metabolic rate. And that's really the goal. 10,000 steps and staying more active throughout your day is it's probably more sustainable if you can't make it to the gym.
And Sheila, by the way, who's a very hardworking interventional fellow, still manages to make it to the gym after long, long hours of doing procedures all day. So I think if Sheila can do it, we can all do it. So she's a little inspiration to us. So the Mediterranean diet, I think Sheila wanted to talk a little bit more about this, but this was a landmark study that was published actually not that long ago, I think a couple years ago, looking at thousands of patients in Spain who basically were put on three different diets: a low-fat diet, a diet that was nourished with nuts, and the other one with olive oil. And the nut and olive oil diet actually did better than the traditional low-fat diet, and it really highlighted the importance that diet can have on outcomes. This actually the diet modification itself actually reduced your risk of dying. So there was a mortality difference from a diet, and I think that that is a very strong, this was a strong sign that, look, it's important that we watch what we eat. Particularly, this study showed that a Mediterranean diet was actually beneficial. And the Mediterranean diet basically was quite liberal in the olive oil intake, as well as tree nuts and peanuts, fruits and vegetables, legumes, and reducing the intake of red meat, while avoiding things like sodas and pastries and fats and processed meats. So when patients that have heart disease see me in the office, I actually do endorse the Mediterranean diet. I think that there's some good data behind it, and it is actually recommended as well by the American Heart.
And this particular study was actually in men and women who had never had heart disease. So when you're thinking about if you have a positive family history, or you're just watching the webinar because you want to be heart healthy for your life and you don't want to have a heart attack, this is the diet to follow. And it's important to emphasize diet because it brings awareness for you to read nutrition labels and to actually practice good, healthy living when you go grocery shopping. But also, even if we told you to exercise for 1 hour a day, or the AHA recommendation of 150 minutes of moderate exercise 3 times a week, that's still a very small segment. What you eat is what you're putting into your body, and based on your risk factors, it can have implications. So what we want you to focus on, because there's a lot of diet information out, is focus on staying away from processed foods, healthy fats like avocado, nuts, healthy oils like olive oil, and really stay the closest to whole grain, whole fresh food as possible compared with processed meats and processed foods. Now let's switch gears, because aspirin is a cardiologist, probably our favorite medication, especially to interventional cardiologists. And it's an antiplatelet medication that in the setting of heart attack is really the gold standard to quiet down the platelets that are causing that clot in your heart. But there are some gender-specific differences when aspirin is used for primary prevention in patients who don't have heart disease or are at risk but have never had a heart attack. So we're going to show you some of that data. When it comes to preventing heart attack, for men, aspirin is better above a certain age. But for women, there was no difference when aspirin was used to prevent heart attack. So then why, when you were just turned 65, did your doctor tell you to go on aspirin if you're a woman who's watching this? That's because there was a gender-specific difference seen. When aspirin was used in women, it didn't prevent heart attack, it prevented stroke. So aspirin plays a very important role in the protection of the blood vessels of your brain above the age of 65. For men, it's different. It's protective to the heart. Again, this is in patients that have never been diagnosed with either heart disease or stroke. But it's important that you understand why your doctor recommended aspirin for you.
And I would say aspirin is very important because a lot of patients are told to take an aspirin and they're not sure why. I think one of the reasons I tell my patients who are female over 65 is, I'd like you to take an aspirin because I want to reduce your risk of stroke. And I think that's what this data supports. There are other indications, though, so be aware that based on your 10-year risk of having a heart attack or stroke, aspirin may also be beneficial, and it is recommended by many physicians to also reduce your risk of total cardiac events. So remember, this is not an easy question, something that you should talk about with your physician. If you have a history of bleeding or any stomach issues or ulcers, then you may not want to be on an aspirin to prevent stroke. So this is a question I encourage you to bring up with your physician. But generally, we recommend that women over the age of 65 consider taking a baby aspirin once a day.
So what about statins? And there's a lot of buzz all the time about cholesterol lowering medications and if they should be used. If you've suffered a heart attack, there is no question that you should be on a cholesterol lowering medication, not only to lower your cholesterol, but the cholesterol medications in patients who have suffered from heart attack actually have a lot of benefit. But this slide and the data that we want to discuss with you today is about patients who have not had heart attacks. And do statins prevent heart attacks in women when used for primary prevention? And so the trend in the data is that women do benefit from the use of statin medications, even when they haven't had a heart attack. Mm-hmm. And when that 10-year risk is calculated, which was actually created here at UCLA, you can understand if you should be on a statin medication. But we would advise that the initiation of a statin medication for primary prevention should be done in an experienced physician, and the dose should be started as low as possible and increased very slowly.
Yeah, and I think one of the take-home points from this is that unlike aspirin, which has a differential effect on outcomes, statins have a hands-down protective effect in both men and women, and this is something that we share with men. And so it's important to recognize that women are not at a disadvantage here. So if you have high cholesterol and a history of heart disease, then you should be on a statin or discuss any alternatives with your primary care or your cardiologist. Very important.
That's a very important point to bring up because data has shown that women tend to get offered less therapies just because, physicians think that they're too frail or they're too thin. And so it's very important to discuss that it's equal between men and women. Now let's move on to some gender-specific differences in the disease process. And I'm going to brush on this very quickly, but this is basically when the heart sits in the body, it sits like a football. And the laces are the main vessel of the left side of the heart, called the left anterior descending artery. And here you're looking at it head on. But if you were to actually zoom in and see what the artery looks like, this is a cartoon schematic. And there's 3 different processes happening. So let's start with the center, because the center is really what happens. Over time, the heart, the blood vessel, actually starts to build a plaque, and it hardens and it develops these deposits. And this is when we talk about cholesterol or calcium in the arteries. It looks like this. When a heart attack happens and you have crushing pain, although if you're a woman, you may not, what happens is one of the plaque here actually breaks off and it creates this thrombus, this very lipid-rich, platelet-activating clot in the blood vessel, stops flow and causes your symptoms. And that's really what's happening. But there's something else that can happen that tends to happen more in women. And it's essentially the same concept, but slower. And it's called erosion. And that's why women can tend to get these stuttering, low, less dramatic symptoms when it comes to having a heart attack. But it all really starts with plaque building up in the cylindrical blood vessel of your heart.
Yeah. And one of the things that I notice as an interventional cardiologist is that oftentimes, the disease can be stable for many, many, many years. And oftentimes there's a trigger. There's a stressful event. There's very often people, when they present with a heart attack, will recall that maybe the week earlier there was stress at work, something was happening in their life. And that stress or that, whatever that event was, can actually trigger that transition between what we call a stable plaque to an unstable plaque. Now, obviously, stressful events aren't the only cause. There are medical issues that can be occurring as well. Things like smoking and diabetes will increase that risk of transition. But what's really important is trying to reduce the inflammation. And we think of atherosclerosis as a disease of cholesterol and a disease of inflammation. And inflammation is often that trigger point and it can be caused by many different things, medical diseases and emotional stress and smoking, for example. So that transition between what I call a stable plaque to the angry plaque is what can cause the development of a blood clot. That blood clot is your body's natural healing process that has actually gone awry, and we don't want that plaque to clot off, and that's what happens when you have a heart attack. So if you do develop chest pain, and that means and you're having a heart attack, what's happening is that your cholesterol plaque is becoming unstable. It's starting to lose flow because you're developing a blood clot. And once you start losing flow to an area of the heart, that's a heart attack, and that's why you feel pain. The most important thing is to go to the emergency room right away and to be treated for the heart attack. And that means what we do is give medications, and if we need to, we may need to go in there and actually open up the artery as quickly as possible. And we say in our line of work, we say, time is muscle. So you don't want to waste time. That can actually increase your risk of losing muscle, and that's really important.
And just to add, that was a great summary. I just wanted to add that you can have stable plaque, get a stress test, and maybe not have a symptom. But that's why just because you have a normal stress test doesn't mean that you shouldn't continue your heart healthy behaviors. Because good heart healthy behaviors, as well as cholesterol medication, if you're at risk for high cholesterol, actually continue to stabilize this plaque. And when you go through stress, or if you dip in your healthy lifestyles, you start to become unhealthy, sedentary, or incur a lot of stress at work, you can easily dip into an unstable situation, even if you had a normal stress test. So understanding your risk factors and maintaining that consistently is very important. So now let's talk about when women do present with heart attacks and we do maybe bring them to the lab. What do we find and what have our studies shown? And so this is an interesting study that looked at women who presented with what we call acute coronary syndrome, but essentially it's the spectrum of a heart attack, anywhere along that sign of an unstable plaque. And there are some gender specific differences. Women incur more delays when they present with heart attack compared with men. And that treatment difference was actually 2.6 times difference in terms of men and women.
And just to understand that the guidelines are that you should be receiving reperfusion therapy in under 120 minutes, and actually ideally under 90 minutes. And look, if you're 2.6 times more likely not to present to the hospital in time, that's going to translate into a higher risk of not surviving the heart attack. So women present later, and therefore we get delays in treatment because we're not presenting early enough. I think that this is a really powerful slide, and it really highlights the importance of outreach. This is why we're here. We don't want women we won't want men or women to show up late, but we recognize that there's a discrepancy in women, and we want to make sure that if you're having symptoms that may be a heart attack, that you do not delay treatment.
So we got to do our part on the physician level to make sure that when a woman comes in and she's having symptoms of a heart attack, that we diagnose it and get her to the cath lab, which is where we would open up her blood vessel or at least take a look within the same amount of time that's recommended really quickly. But there's something else. What about you? What about if you're experiencing something, but you just don't know if you're really having a heart attack? And our physiology didn't make it easy being a woman. So men have a dramatic crushing chest pain. They know that they're having a heart attack. It's pretty much typical to what you see in the movies. But women can have something very subtle. It can be as subtle as unusual upper body discomfort, some shortness of breath, a migraine, extreme fatigue, some nausea. And what we typically like to say is that if you feel anything abnormal from the navel to the nose that's out of the ordinary, that came on with exertion or during a stressful situation and continues at rest and doesn't go away when you stop walking, you should probably go see the doctor right away, come to the emergency room and get it checked out.
Yeah, and I was going to say, some women do present with chest pain. Some women present. I've seen patients present with hiccups. I've seen patients present with back pain, nausea. Sometimes you just quote, just don't feel right. And so it's important to read your body, to understand your symptoms, know how you're feeling, and not to ignore anything. Just important to say that patients with diabetes, both men and women with diabetes, also can present with less obvious symptoms, and they can have what's called even silent heart attacks, where they may not feel things the way people without diabetes feel. So I think there's atypical symptoms are present in both men and women, but they seem to be more common in women.
And Dr. Press said something very important. Don't ignore anything. It's very easy to let that to-do list and task list really drive your day. But when it comes to feeling something abnormal in your body, you have to get this checked out. Because if you don't, and you have a silent heart attack, you run the risk of heart failure. And if you can't take care of yourself, you're not going to be able to take care of anybody else, including your to-do list or your family and your loved ones.
So this is interesting because this is a study that looked at women who presented to the cath lab. And we say cath lab, what we mean is for an angiogram or coronary angiogram. And that's a procedure where we go in to your heart with a catheter and we inject a dye and take a picture with a camera, and we can actually see what do your arteries look like. And it seems like in women who present with heart attacks, the incidence of what we call normal heart arteries is actually higher in women than men. Does that mean that they're not having a heart attack? No, it just means that they're not having a classical heart attack. We talked about the classic heart attack earlier, and that's basically a plaque that's formed from cholesterol that builds up over time. There's a trigger, that plaque gets angry and then develops a blood clot causing a heart attack. That's the typical presentation. Women can also have an atypical presentation of a heart attack, and they may even have what looks like a normal coronary artery on the angiogram. And this is, again, what we talk about, some of the more less common causes of heart attacks, and they can happen in men and women, but seem to be a little bit more prevalent in women, and that's important.
Just some more data.
So those are, you can see, so 30% of women had normal angiograms compared to 14% of men in patients who came in with acute coronary syndrome. So what this means is that there are other causes, and we're going to go into that in a little bit.
And I had mentioned that there's a spectrum of heart disease. So UA stands for unstable angina, those stuttering symptoms. And when we talk about the full-on heart attack, total occlusion of the blood vessel that's completely closed, you can see that women actually present more with that stuttering, unstable angina, where the pain may be waxing and waning, coming and going, but it's not going away. More women present with that compared with men, and less of them present with that total occlusion. So that's also important in terms of treatment delays and the recognition of it in the cath lab. So this is an angiogram. That was an angiogram of a woman, and it's not playing, but she presented with unstable angina. And when I brought her to the cath lab, what I found was that she had a lot of slow flow in the blood vessel, consistent with almost a plaque erosion. And so what is that? Men tend to develop atherosclerosis or disease of the blood vessel of the heart different from women at times. Men can develop a focal stenosis, which is a very, typical tightness in the blood vessel from cholesterol plaque. It can break off and rupture and cause a total occlusion. Whereas women can actually develop more diffuse atherosclerosis. The disease is kind of throughout the entire vessel, making it smaller, and at times can have a spasm quality to it as well. And we tend to see that more in women compared with men. So here's just emphasis on the focal aspect, and here more diffuse. And that diffuse disease runs the risk of plaque erosion as well as spasm. So let's talk a little bit more about what that could mean in terms of a larger microvascular disease process.
Yeah, I think a lot of my patients actually have heard there's this name called Syndrome X. I think people know that name because it sounds like kind of scary and sort of like, who knows what is Syndrome X? It's sort of a black box of disease. But what it is basically, a patient who has chest pain that's consistent with angina. And what's angina? Angina is pain with exertion, and it's from usually lack of blood flow to an area of the heart. And pain with exertion or angina can occur from, as we talked about, narrowing of the major artery, but it can also occur with narrowing or abnormalities in the branches of the arteries. And I like to use the 405 because I live in LA and there's traffic. But again, anywhere you live, you can take a highway from point A to point B, and it can be backed up, and that can cause problems getting the blood flow from point A to point B. But you can also go off the highway and you can take the side roads, and the side roads can also give you delays in getting from point A to point B. So it's important not to forget those side roads, and those are basically the branch vessel disease. And we know that women who have typical symptoms of angina, who have had normal angiograms, can still have abnormal stress tests and can still be at some increased risk of having cardiac events later in life. And we call that disease process microvascular disease, or quote syndrome X. And the treatment is really, again, all the things that we've been talking about in terms of prevention. We may consider a baby aspirin. We may give the medications such as beta blockers or calcium channel blockers or nitroglycerin to relieve symptoms. We may be more aggressive about lipid lowering therapies. And so it is important that if you have chest pain, again, that you see a doctor, cardiologist if necessary, to see if you may be at risk for having or you may be having some of these processes.
So even if you don't have that focal stenosis, you still may benefit from medical therapy to treat your chest pain because of the web-like side streets that could be blocked. So to summarize, women may have non-obstructive or non-focal coronary artery disease, and at times you'll still see abnormal stress tests. And it's more difficult to assess in women, and that's why they might need to get a stress test or an angiogram. But the treatment might not be a stent. The treatment might be medical risk factor modification. But these are important differences in coronary artery disease, and both in the stable disease when you just have chest pain symptoms, let's say if you were at the gym, or when you present with a heart attack. And awareness of them is important.
Yeah, so I think this is probably one of the most important messages I tell my patients. We know that smoking and diabetes and high blood pressure and family history and elevated cholesterol all can lead to a heart attack. But what we often forget to talk about is stress. And stress is a major risk factor for heart disease and can, be easily overlooked. Stress is something that we all live with, and it sometimes can be more difficult to deal with. And if we don't at first recognize that that's an issue, then it becomes impossible to treat it. So if you feel that you're under a lot of stress, recognize that one of the reasons that we want to reduce that stress is to protect your heart. And it's important that we understand that one of the mechanisms by which stress can increase your risk is that stress leads to what we call the catecholamine surge, or high levels of hormones that are actually used to be adaptive for example, flight or flight. So, evolutionarily, we adapt to stress by increasing our heart rate, by increasing our blood pressure, increasing our respiratory rate. All these things are supposed to be adaptive, but if we live at that level all the time with high heart rate, high blood pressure, emotional stress, then that is not healthy. And so try to first accept that stress is there. We can't get rid of all of it. Recognize if you think you have a problem with stress, and see if you can minimize the stress. And minimizing stress is one of the hardest questions that patients ask me. There is no magic pill. There's no, one solution for everybody. But things like, meditation, getting good sleep, getting support, family and friends and a happy life is so important. And so don't neglect the basics of life, like good sleep, happiness, exercise, meditation, yoga. So there are many, many different ways of reducing stress. And I just tell people not to let it get overwhelming, because we don't want to see you have a heart attack from a stressful situation.
I'm smiling because Dr. Press has definitely helped manage my stress this year as a very busy interventional fellow. And we were rushing from different sides of town to get here today. But I can just imagine what stress you all went through to just make sure you scheduled to watch us. But I wonder if when you're watching this, you're thinking, oh, but I can't check in within because my husband probably is going through more stress, or I can't let him know that I felt something funny, or I need to see the doctor. So do men and women have differences with stress and the heart? And they do. So please put yourself first. I know his job or her job or your partner's job might be stressful, but if you feel something abnormal, stress affects your heart worse than men. And so what this study shows, and this is a picture of one of the ways that we do stress tests in the heart. It's a nuclear stress test. We look at a radioactive tracer, both when the heart's in rest and when they're under stress. And we look for a filling defect. When the heart is stressed, if there's disease there, we'll see that the donut that was full at rest is no longer full, and there could be a blockage there. What we have found is that women with anxiety actually have more stress on their stress test, what we call ischemia, compared with men with or without anxiety. So it's very important to know that stress has a gender-specific difference when it comes to blockages in the blood vessels of your heart. And then there's something else. You may have heard of broken heart syndrome or stress-induced cardiomyopathy, but I think broken heart syndrome is way, way better in terms of understanding this disease process. And I'm going to let Dr. Khalfan describe it, but essentially women have presented with heart attacks and they have completely normal blood vessels, different from syndrome X, different from plaque erosion, but their heart as a pump has suffered and doesn't pump normally. And what we have found is that there was a stressful event in some time span before they presented with the exact symptoms of a heart attack. And this is called stress-induced cardiomyopathy, broken heart syndrome, or Takotsubo's cardiomyopathy.
Yeah, and the most important thing is that we can only make the diagnosis by excluding a typical heart attack. So if you've been given that diagnosis, you would have to insist that you've had the angiogram to prove that it's not from any other cause. If you have a chest pain and you're having a heart attack and you go to the angiogram suite and the cardiologist tells you that your arteries are normal, we will look for this process. It's actually very well described, very well sort of recognized disease, and it's, again, like Dr. Sheila said, it's called Takotsubo because it takes the shape of an octopus fishing net, which is the name for the Japanese name for that. So you can see that that's what the stress cardiomyopathy looks like on the angiogram, and that whole section of the heart is stunned. The only part that's contracting is the base of the heart. So it can be pretty profound. I always like to put the positive spin on things, and my positive spin on things are that most people with this disease actually recover completely within a month. So if you have Takotsubo cardiomyopathy, you will recover. Most of the patients will recover. People with a history of Takotsubo can be at increased risk of recurrent Takotsubo. So again, avoiding those triggers, making sure that your blood pressure is well controlled, discussing whether you need a beta blocker to reduce that blood pressure, reduce that catecholamine surge is important. Again, all these things should be spoken to with your cardiologist or your internist. But it's an important finding that we see on occasion.
And it can happen because of that catecholamine surge of stress that Dr. Press talked about earlier. So now, hopefully, we can address some of your questions. And as those questions are coming in, we're going to share with you some really fun, heart-healthy tips that we want to kind of reemphasize some points. And hopefully, it'll lighten everything up and get you going into this heart-healthy lifestyle we want for you.
Oh, and by the way, this is our website, so heart.ucla.edu/women. If these slide decks, there's actually many more of these. It's a card deck. The PDFs are actually on the website. So if you forget what we said, or you want to read about some more heart-healthy facts and tips, please visit our website, and you can see all about it.
And you can also follow our hashtag. It's UCLA Women's Heart. We're very active on Twitter as well as Instagram. All right, so this is something we actually didn't emphasize as important as it is. If you have a first degree relative, a parent or a sibling, or a second degree relative, an uncle or a grandparent who has suffered from early heart disease, you're going to be nearly 10 times more likely to suffer heart disease in your life. So it's really important when the doctor is asking you, have any of your family members ever had heart disease, that you really dig deep, think hard, because that knowing that and knowing the age that they had a heart attack actually affects your risk right now.
And I think this is important because it's speaks to one of the causes of heart disease, which is still a genetic predisposition. And when you have a family history of something, you are going to be at risk based on the fact that that disease may have a genetic cause. So I've seen patients who do not have any of the traditional risk factors and still have a heart attack, and they will ask me, why did this happen? And if you go back and you look at their family history, you may find that it runs in your family. So this is an important thing. It's part of our basic history when we meet patients and assess risk. And so it's even more important if you have a family history that you get on board with the heart healthy lifestyle, suggestions we talked about, and talk to your physician about whether you need to be on an aspirin or a statin. And of course, your blood pressure needs to be perfectly controlled.
This one's probably my favorite.
Well, I don't know about your favorite. These are my favorite holidays, but I don't like to hear that they're also when people have a heart attack.
Well, I think it's important for everybody to know because the holidays are so stressful.
Yeah.
So heart attacks peak during holidays, which is really sad. But now that we're telling you, you can prevent it. Some of the highest risk days include the day after Christmas, or around Christmas time, Christmas Eve, as well as following New Year's Day. But this can be translated to during major sports events. We've seen this during Thanksgiving, even birthdays, Mother's Day.
Anything that's basically a potentially stressful event. But yeah, I mean, I can imagine why Christmas may be, if you've been up all day cooking, or maybe, stressful about, your shopping.
Yeah, or some family member. Family is there's always some stress involved. So I think what we want you to take away from this, and also speaks to Monday mornings, are also another time where heart attacks can happen. So during these stressful times, check in within and really ask yourself, wait, am I okay? Everything's going to be okay. Try to get those coping mechanisms that we're trying to emphasize, whether it's the gym or healthy eating or a handful of nuts or lighting a candle and taking a deep breath. Whatever really works for you to calm down, you're going to need during these holidays or stressful moments in your life.
I really like that. Check in within. I'm going to use that.
I got that from my trainer at the gym.
That's great. All right. So a person who...
I think we did this one.
Sorry. Oh, get your Z's. So try to get 7 to 8 hours of good quality sleep per night. This is not so easy for many people. Insomnia can be very difficult, but don't give up. Try to get your sleep. We know that good quality sleep is very, very important, not just for your emotional health, but for your physical health. And, sometimes I feel bad when we have to call Sheila in the middle of the night and she doesn't get any sleep. So we tell her to go home and try to catch up on her 7 to 8 hours. But do the best you can, and it's important.
I think the point there too is that try your best to be as healthy as possible. So if you can't get more than 6 hours of sleep, get a good dose of vegetables in, get a good workout in, try to take the stairs more, so that you're on overall more healthy. I think this is really important. So we talked about the Mediterranean diet, but we definitely don't want you eating 3 bags of walnuts a day. So portion control is really important. How do you keep your portions down when it comes to eating nuts?
Well, I try to look at the amount and try to keep everything less than a fist size is pretty much my general kind of rule. I try, to try to eat more frequently in terms of avoiding periods of hunger. You don't want to get into a meal feeling extremely hungry, then you're going to potentially eat more. So some people suggest having smaller meals, potentially more frequent, and looking at your portion size.
Yeah, and I think, using things that are available to you. So if you're at an office, you're sitting at your cubicle and you have a Post-it note and you have a bag of almonds, this is great. Just march them out on your Post-it. And or a Trader Joe's, not to advertise for them, but a lot of companies have prepackaged nuts. That's what I do. I just grab a prepackaged small bag to keep my portion control down. And really all you need is a quarter size. So there are a lot of fat and calories in nuts. We want you to use them for within the portion size that's recommended, which is about a quarter ounce or a small ounce. So this is important. My little sister is a dentist, so this one is near and dear to my heart. People who brush their teeth only once a day are more likely to develop atherosclerosis, clogged arteries, than people who brush twice a day. And that's because there is a link between gum disease and periodontal disease and the heart. And it also has to do with risk factors. So diabetics also are more at risk for periodontal disease as well as heart disease. Do you emphasize this to your patients?
I try to. I think that we sometimes forget this fact and we sometimes just take it for granted. But also seeing a dentist regularly and keeping good dentition is so important, right? Because, we have many patients who come in with advanced valve disease, for example, who are going to maybe need surgery. Risk of infection in terms of heart disease, heart valve infection is high in people who have pre-existing dental disease. And so I would say brushing your teeth and going to see your dentist regularly is very, very important, and to do that throughout your entire life.
Yes.
All right. So I think we can conclude here, and I think we've pretty much hammered down that we know that heart disease is the leading cause of death for women, and we know that there are disparities. One thing that's important is for us to always remember to try to promote that we need more research in women to highlight these differences and understand them better, so we can continue to do the work we've really kind of benefited from.
Yeah.
So, and again, we're happy to answer any of your questions. If there's anything that we haven't touched upon, please let us know.
Yeah.
Go to the last one. Oh, this is our team. I'm sorry, we should introduce. So Dr. Carol Watson is the director of the Women's Cardiovascular Center. Myself and and John Kishar are co-directors, and as well as Sheila, who's our head of media and very, very, very active member in our center. We have several other people on our team as well, and if you have any questions, please go to our website.
So we'll take some questions now.
Okay, so great talk. Thank you for the information. Wonderful that you enjoyed it. So Sheila, want to talk about PFOs?
Yes. So the question is about, could you please discuss patent foramen ovale, and that's found by accident in older women, and whether they really need to be treated. So a patent foramen ovale is a structural abnormality in the heart. There are 4 chambers in the heart, and the PFO is one of the congenital abnormalities that's found in 25% of the population. It's a hole between the 2 upper chambers of the heart called the left and right atrium. And because it exists in 25% of the population, we don't normally know about it, do anything about it, and it's fine. But then who are the people that present to physicians, and then should they be treated? There is a syndrome that can happen, and it's a spectrum of stroke. It's called cryptogenic stroke. What all that means is that a patient had some type of stroke symptom. So whether that was dizziness, loss of function on one side, whether it was permanent or transient. It usually tends to be transient, but it's a stroke that happened that may have resolved. And those patients get studies that will show us. One is a transesophageal echo or a surface echo, but we make a diagnosis and we discover that there's a PFO. Just recently, there has been, by the FDA, an approved use of a closure device that we do here at UCLA by Dr. Jonathan Tobis to close PFOs. And it should be done if you've suffered stroke or if you have very large pressures in your heart. But it's a case-by-case discussion. that is a concerted effort between structural cardiologists as well as neurologists. So if you know anything about having a PFO or you're concerned, you should make an appointment to get checked out and see if you need to get it closed.
Yeah, I would say most times, if a PFO is found incidentally, there's nothing to do about it. It's usually maybe take a baby aspirin based on your risk factors, and really we don't close them unless you have a history of a stroke, at least on an aspirin. And in certain situations, we may decide to close it. But I think it's a complicated question that you want to talk to your physician about. So the next question is, could you please discuss the risks and benefits of TAVR procedure in women 90 to 100 who are otherwise in good health? So TAVR is a relatively new procedure. It stands for transcutaneous valve replacement. And basically, it's aortic valve replacement, and it's a procedure where instead of having open heart surgery in patients who have what's called aortic stenosis or narrowing of the aortic valve, they can have the valve replaced through a small catheter in the groin, and the catheter will deliver the valve to the heart without having open heart surgery. And it's approved for patients who are at least high or intermediate risk of having open heart surgery. We know that it's a very, very, very good option for patients who are high risk. So often elderly patients, maybe greater than 90 years old, who are otherwise in very good health, may do very well with the TAVR. And so it's a very something that we specialize here at UCLA. We have a TAVR program with Dr. Wilsa and Dr. Oj Aksoy and Dr. Behi Rabbani. So we have multiple physicians here who have a TAVR program, and I think if you have yourself aortic stenosis at an advanced age or relative at advanced age or who may have risk factors for open heart surgery, to certainly consider TAVR as a very, very, very equal, if not potentially superior option than traditional surgery.
And it's interesting that there was a question that was brought up about TAVR, because TAVR is one of those advanced therapies that we actually took out of our talk.
Oh, yeah.
And it has a gender benefit for women.
So women actually benefit more from TAVR than men. And again, the good news for us is that many of the new evolving therapies are showing at least equal, if not improved benefit in women. So this is good news for us. So what do you think we want to do next one?
Yeah, why do you think there's such a difference between men and women in regards to symptoms of ACS? And that's acute coronary syndrome, or the spectrum of a heart attack. And a lot of it is what we had shown in that picture of how atherosclerosis, well, first and foremost, I think for a long time, science was men and women were thought to be smaller men, and that's not the case. We have a completely different pathophysiological breakdown, and that's why certain medications need to be dosed differently in women compared with men. So when you look at the disease process, it's not the same either. And women tend to have diffuse disease. We tend to have more plaque erosion, so our symptoms might be less dramatic. They might be stuttering, and that really begs the difference. Women might be presenting with less dramatic heart attacks because they're not getting that total occlusion. And so that kind of makes everything a little bit harder for the diagnosis. But a lot has to do with the genetic makeup and the differences in our stress management as well as risk factors.
I think that's a difficult question. I actually don't know the answer to that. I don't think anybody can say exactly why women may have atypical symptoms. I think Dr. Sani's point is very well taken, that there's a spectrum of diseases that women may have more commonly in men, which may have more atypical presentations. But even in women with the typical heart attack pain, it's heart attack that we talked about, the occlusion, they may still feel something a little differently than the classic description. I also want to emphasize that, men also present with atypical symptoms, and I think that we should all be aware of these, the spectrum of symptoms, that it's not only just the sign of the crushing chest pain. It can be other things: back pain, shoulder pain, jaw pain, nausea. And I don't want to let us all forget that it's not, women may have a higher incidence of atypical symptoms, but they can also occur in men. We want to raise that awareness for both men and women.
I'm going to take the last one because it's someone who is afraid to see their cardiologist for the first time, but really enjoyed our talk. And I want to really emphasize that the Women's Cardiovascular Center at UCLA is a very non-judgmental,
Very
fun,
friendly,
very friendly. Dr. Calfon Press is so easygoing and nice. And really, I think you should just ask yourself, why are you afraid? Because if you're afraid to find out about your risk, you probably need to see us right away. But we're going to help you along the way, and we're going to make it our priority to keep your heart healthy so that you can live a very long, healthy life.
Yeah. And again, there's no stigma at all. I mean, this is, again, we all are at risk. It's a disease for all of us to pay attention to. It's not one person's disease. It's a community that we need to really support each other. At UCLA, we have a lot of support groups for women. We work with Women Heart, who meet once a month. There's a wonderful group of women that get together and support each other to get through this. So there's a lot of help out there. Please don't hesitate to contact any of us if you have any other questions. But I think we're pretty much wrapping up. It's 1 o'clock.
Thank you.
Thank you very much for attending our webinar.